Alright, well, good evening, Dr. Bautista. I'd like to take the time and the opportunity to give you thanks and appreciation for allowing me to do the second portion of this physical assessment. We spent a lot of time in the lab earlier today. As you can imagine, came home, reviewed some stuff that I needed to get done for this assessment. So there's 3 areas that you wanted me to key in on, which is the abdomen, the musculoskeletal, and the neuro. So waiting for my son this afternoon to get from school, come back home, and we're going to use him as my patient. This is be sent to the third. Say hi.
Hi.
Okay. So we're going to start off with the abdomen first. We're going to start off with the inspection, the shape, the size, contour, the skin, the vascularity, and any pulsations. Can I have you lay down for me, son? Once again. So, upon inspection of the shapes, his contours looks round. I didn't see no abnormalities, no hypopigmentation of his abdomen, no notable undulations, any pulsations. I'm going to also take now his bowel sounds. I'm going to look at his renal, his aortic region, and femoral region. I'm assessing for bruise, any abnormalities. Okay, so no bruise were noted. For the sake of time, I'll touch on some of the items that we previously went over, just to save some time for the sake of time. So I'll try to move along fast in this video. And as I mentioned, it's auscultated for bowel sounds, the aortic region, the renal region, and the femoral region. We're going to percuss the liver, the spleen, and the abdomen. The abdomen is shits on tympanic, spleen, liver, all obviously going to be dull. We did that earlier with the young lady that assisted us at our meeting together for the physical assessment. So we're going to move on to palpation, the liver, the spleen, the inguinal lymph nodes, and we're also going to assess the femoral nodes. Very well. So the liver span is normally going to be 6 to 12 centimeters, which is a normal finding. If we were to assess it, we would start from an area of resonance and palpate down to an area of dullness. Then we would mark with the marker N. Then we would start from an area from tympani and mark our way up to dullness, and we would mark. And that span should be 6 to 12 centimeters. And just assess his liver, assess the spleen and the kidneys. All we have them do is take a deep breath, kind of hold the breath so that we can kind of in the contour or their abdomen. And what I did was I put my dominant hand underneath and the other hand to dominate the palpation and press in deep. It was not palpable the kidneys, the liver, not palpable nor the spleen, which is a good finding. The spleen's going to be engorged. You're going to see that most likely in a patient that's like has liver issues, like alcoholics would be one example. In the back also, because the kidneys are there, we would also assess for the CVA tenderness, so we would palpate the right and the left. If there is tenderness, that could lead you to suspect UTI. Obviously, a person who had a UTI just kind of let it go on and never addressed it right away until it got pretty bad. Next, the abdomen, we do light palpation, we do deep palpation. Now there are several exams that we can do that can help you or lead you to suspicion of certain things. For example, on the McBurney's point, We spoke earlier about is your umbilical or umbilicus to the iliac crest, and you will work a third of the way down, and in that point you would compress or palpate, deep palpation, and then if it hurts, then that would lead you to suspect a appendicitis, right? So next thing we spoke about was if somebody had like a cholecystitis, a gallbladder problem. So we would appear in the right upper quadrant. It's going to be called your Murphy sign. And then one other thing that we can do is a Rosing sign, which is in the left lower quadrant. When we palpate into the left lower quadrant, we can feel the pain in the right lower quadrant. Some books may refer to that as a referred pain. However, for this test, it's called the Rosing sign, where we compress in the left lower quadrant. I would feel it on the right. Again, that would lead you to suspect appendicitis. This can also lead you to even suspect peritonitis. Another exam that we can do while they're laying down is called the Ilisovis sign or Ilisovis test in obturators. So with me, since he's already laying on the bed, I would get the leg, I would flex the knee, and I would externally rotate it. This undenies pain. Is relatively healthy, but nevertheless, this is one of the exams. Now, I know it says left side, but we'll pretend it is right just because of the way we're set up here in the apartment. Now, the next test for the soul sign would be if he's laying on his side. And it's straight. I would pull back this leg. Again, if it was painful, if there was pain, it would lead you to think or suspect either peritonitis or your appendicitis. So these are two different types of exams you can also do. Excuse me. You okay? Okay. All right. So next we're going to move to musculoskeletal. Let's stand up. So here we're going to assess for spasms, any fasciculations. We're going to assess for any swelling, any nodules, tenderness, deformities, any discomfort and range of motion, and for strength. So first of all, we're going to start with the temporal mandibular joint. I'm inspecting. I don't see any abnormalities. As I can press and palpate. So no tenderness, no pain. I don't feel any crepitus. Can you open your mouth? Close it. Can you check it? Okay, so we got full range of motion. Can you move your chin now? There you go. There you go. So strength is 5 out of 5. Okay, look up. Straight. There you go. Chin up. We got full range of motion in the cervical spine. And I got strength 5 out of 5. Now with the shoulders, we're going to mirror after the shoulders. Move straight out. So we have abduction, adduction, right? Flexion, hyperextension. We got the external rotation. We got the internal rotation. Okay, very good. Now moving on to the joint here. We have on the joints that we're going to do for his sternum here. We're going to look at what's called the sternoclavicular joint. We're going to move over to the acromion joint. And then in here we have what's called a bicipital groove. We'll search for that. And then a little furthermore, it will be called the glenohumeral joint. Some books will refer to those joints of the shoulder as the shoulder complex. Just FYI, I read that earlier. From the shoulders, now we're going to move to the elbows. We're going to assess the joints. We're going to note any tenderness, any masses, any abnormalities, or any deformities. None are noted. Either at the condyle region, there's nothing there. Okay, remember how I told you how to use this? First extension. So we have extension, flexion, right? We're going So straight is 5 out of 5. We're going to assess the wrists. Okay, so we got the wrist here. There's no any tenderness here. So remember how much you can do this. So we got radial deviation, ulnar deviation, flexion, and extension. Very good. So we got strength is 5 out of 5 here. We're going to move on to the fingers. Okay. So we have abduction, adduction. We got extension and flexion. Very well. No? So we're checking the phalanges and phalangeal joint and then the metacarpal. No? And we would test these for all 10 fingers. Okay? Okay. Now we're going to do the hip. Just go like this. Turn it this way. Like that. Okay. Turn it around for me. Remember we told you to move forward? This left foot is touching the floor. And then move up slowly. Very good. So we have forward bend, backward bend, and full range of motion on the hip. However, because he was already bending over, forward bend, I went ahead and took that time to palpate the spine, inspect the spine, and we're also going to look for scoliosis. So we can continue with the range of motion. We're going to do the knees. Have a seat. So I would assess the tibial plateau on both sides, looking for the tibial plateau, looking for any deformities or any tenderness, any pain. Do you have any pain or tenderness? Or there's no pain or tenderness? Can you lift your leg forward? Very good. Very good. So I have extension and flexion, full range of motion on the knees. We're going to move on to the ankles. Now, on the ankle, watch your legs. So I have dorsiflexion, bring it down. Okay. We got plantar flexion. So the couch is too close to the floor. His feet are not dangling, but he's a little dorsiflexion, plantar flex. And then we got the rotation. We have all the joints are appropriate. I'm going to check the strength of 5 out of 5. That's what we're going to look for. Okay. So bring your legs in. Bring them. Same thing. Bring them up. Bring these up. Bring these up. Toes. Yeah. So strength on his knees, his ankles, and his toes are 5 out of 5. I assessed his toes, his phalanges, and his metatarsal. Another thing that you want to check too is your medial and your lateral malleolus, making sure that there are no deformities there. Also assess the Achilles tendon for any pain. We palpate for that as well. Now moving on to, so we did that strength. Now we're going to do the Phalanx test and the osmoskeletal. Can you stand up for me? Now the Phalanx test is what we assess for something called carpal tunnel syndrome. And one of the ways that this is assessed for is and we normally hold it for about 10 seconds. Very good. And then use your hands. Do you feel any tingling, any pain? So obviously a positive test would be if the patient has any tingling, sensation, any pain, discomfort, that would lead you to believe or suspect that they have a carpal tunnel syndrome. Now moving on. So I know earlier in the day we spoke about like a differential diagnosis or what could possibly go on, or if they had a, like for example, like you mentioned about a rotator cuff tear. So for several, you got it? Everything good? So one of the tests that can be to examine the rotator cuff tear are like the Neer test and the Hawkins test. Which I totally forgot earlier, was the forward flexing of the shoulder at a 90-degree angle, flexing the elbow to 90 degrees, and then you're going to internally rotate the arm to its limit. Obviously, if there's any pain, any discomfort, any popping, maybe some crepitus. It depends on the degree of the injury. Obviously, pain would be the first indication, and that would be concern for a rotator cuff tear. However, moving on forward to the knee, we spoke briefly about an ACL tear, maybe even a meniscal tear. So an ACL tear, one of the exams that can be done, or the test, it would be called a drawer test. So examination of the knee for the anterior and posterior aspect for stability. We would flex the knee at a 90-degree angle. So let's pretend it's a 90-degree angle here. And then what I would do is get both my thumbs and put on a tibial plateau, and then we would pull the joint, or we would pull forward toward us, or jolt, not joint, but jolt. I meant to say jolt. So we would hold it like this. Right. Of course, we're sitting down. The clinician would sit on their foot to stabilize them, and they would put their thumbs, both thumbs, in the groove here in the plateau here, with their fingers behind their calf, also helping with or displacing the hamstring, and then jolting forward like that. Now we would do that on both sides, bilateral. Obviously, we want to start with the non-injured side, only to have a baseline, and then we would compare that with the affected knee. Now, some doctors will say that a positive finding greater than 5 millimeters for the anterior tibial translation may present or could be considered an ACL tear. It's important to note that one of the terms that are used for that, let me get my water. Here's my water. Is that for the displacement, they use another term called anterior translation. The other term is displacement. So translation is more the term that you're going to hear most often, especially with like physical therapists. And moving forward, we're going to talk about the meniscal tear, which was the Lachman test. One of the things about the Lachman test is kind of similar to the exam we just spoke about, the drawer test. The leg is flexed, the knee is flexed at 80-90. However, in this one, the Lachman test is that the leg or the knee is going to be flexed at a 15-degree angle, and then it's kind of basically the same idea, except we're going to have one hand at the distal portion, the femur, the other hand on the distal portion of the tibia, and then with that, then we kind of pull. Of course, you want to start off with the non-injured side to have a baseline, and then you would compare that with the injured area, injured knee. Moving on to the McMurray's test, also is for meniscal tear. Okay. We would do that for medial and lateral. So the medial, we would use the external rotate the foot until the knee reaches its full flexion and full extension. So a positive finding is you're going to hear a click, a pop, any pain, any apprehension. To know if it's the lateral meniscus, and or aspect of the meniscus, you're going to internally rotate the foot until the knee reaches the full flexion, and then they're going to obviously fully extend so that you can assess to see if you hear any clicks, pops, pains, or apprehension, which would be a positive finding. Obviously, it's not a good deal, but I've seen it happen. Okay. Moving on to a neurological exam. So we're going to talk. I'm going to ask them a few questions real quick.